Jeff, I want to pick up on this theme that was just raised by Grace Marie about supply. And I guess there are two issues. One is if you expand access, and if you look at the Institute of Medicine studies on what appear to be depressed levels of demand and medical care because lack of access or various ways of barriers because of cost, is there enough capacity in the system for quality care to handle what could be a rise in demand? And secondly, could you talk a little bit about and expand on Senator Bennett's reference to evidence-based medicine and maybe some of the work you've been doing at Mayo and that Mayo's been working on in this area?
Well, I think the question is a good one about the capacity, and is there capacity in the system? We have some tests going on today in Massachusetts and other places where I think the jury's still out about some of that as to whether, as you introduce a large population into the healthcare system, it's probably a question of where you have the capacity, because today we're inefficiently treating patients in emergency rooms, as Senator Bennett said, very inefficient care late in the care process. Probably a lot more of that care needs to happen on the primary care end of things like Intermountain and Mayo and other places are doing. We believe that one of the things that is really important in order to fix the healthcare system is to create a lot better value than we have today. It's a broader definition of the term quality. For us, it's the outcomes, the safety, the service over cost over time for patients, and that's the kind of measures that were referenced in the Dartmouth study. For us, refining the system or reforming the system, the very first thing we have to do is to create better value. And if we do that, and we do it well, and we may not be able to do it sequentially, but we're going to have to do them at least concurrently. If we create better value, we'll eliminate a lot of the waste that's in the system today. And if we pay for that value, frankly, the system today pays for waste. It pays for widgets that are performed or treatments that are performed. It doesn't pay for good outcomes or treating people sooner rather than later. So if we do some of those things better, I think it probably won't be we could very well have some short-term problems, but long-term, I think we'll have a much more efficient system. And probably there is the capacity to deal with it. We're dealing with it today in a very inefficient way. If we create a more efficient system, we ought to be able to do it better. Your question about evidence-based medicine, I think that, I think many have written about this. It's something that, we believe we practice well at Mayo. Again, a lot of organizations are seeing the value in this. And there really aren't, I think one of the things that needs to be in healthcare, any healthcare reform, is a good process for evidence-based medicine. There are other terms put to it sometimes. Because really there isn't a lot of research that's really translated into practice the way it ought to be done today about the most effective care models, the most effective treatment modalities, and a quick translation of what we learn in the laboratory into the practice. Even in our organization, where we talk to each other and are literally across the hall from each other, some of that transference of knowledge doesn't happen as quickly as it should, and I think it's an important element of a better healthcare system down the road.